So thank you very much for having me back. I'm not going to take a lot of your time today because I'm going to give you the 30,000-foot view of what I think you need to perk your ears up about what's going to happen with lung cancer that's going to supplement what Derek just talked about. So where do I think the breakthroughs are going to come with lung cancer, and specifically early lung cancer? Well, Derek has told you about the people who are at risk for lung cancer. He also told you that there are 10 million people that could potentially be at risk for this. Well, some are at low risk, some are at high risk. We need to figure out exactly how we predetermine who is going to get the screening CT, because what Derek also hinted was that in the National Lung Screening Trial, it took 350 CTs to find one lung cancer. So we'd like to be more efficient than that and not have to spend all of the taxpayers' money to find a lung cancer. So maybe blood tests will help to diagnose lung cancer like we have in other diseases, or maybe even something crazier like breath testing. Maybe we can image better, and obviously the earlier we find things, the less I have to do, and we always want to make it less invasive for the patients. So as Derek said, lung cancer is number 3 in incidence. It is number 1 in cause of death as far as cancer. The 2015 projected numbers are close to 250,000 people being diagnosed with lung cancer, and about 160,000 unfortunately dying from lung cancer. And worldwide, in 1 year, in 2008, it was estimated there were about 1.4 million deaths from lung cancer. Derek has shown you that screening does save lives, and there's no doubt about it. However, let's look at these numbers. For those undergoing at least one screen, the number needed in the National Lung Screening Trial was about 320 CTs to find a lung cancer. So let's go back and say that if everybody who develops a lung cancer gets a screening CT, that would mean close to 71 million CTs in the United States. And if there's 70 million CT scans per year, and if there's 319 million people in the United States, that's about a CT scan for every 4 people. So what we need to know is, are there other ways besides age, smoking history, that sort of stuff, just to define a patient and make it more accurate to define their risk? So what we really want is this thing. Anybody know what this thing is? Well, let me give you a hint. This is used by a doctor. Unfortunately, that doctor is no longer with us, but that doctor is Bones. That is a tricorder. So obviously, we're looking for something that's going to be so simple, that's going to be able to sum so much information about a patient that then it's going to tell us that he either has something, doesn't have something, or he's at risk for something. So Derek already told you about the U.S. Preventive Task Force. They've defined your risk as age, how much you smoke, and the time interval from when you stop smoking. But there's some experts who think that there's more mathematics that's involved here, that you can actually use other parameters and do just as well, or lower that number of the number of scans needed to find a lung cancer. And in fact, there are certain models. Look at all these demographics. These are all things that you can get from a patient with the exception of an X-ray or a CT scan. But this you can ask about or you can see. And this is one of the models that these statisticians are talking about. And in fact, this model has been applied in retrospect to all the patients in the National Lung Screening Trial to define what the risk of every patient was and to see whether it holds true if you could define who's at the highest risk and who needs to be screened. Those curves, if I have a, yeah. This is the risk for developing lung cancer, defined by that model. And what you see are two curves here. These are from the National Lung Screening Trial. The upper one is how many deaths you get if you use chest X-ray. The lower one, the red one, is how many deaths you get if you use CT. But these curves were drawn from this model. And what you see is that if you're at low risk, you really don't have any advantage at all of chest X-ray, but at a certain point, this 65% number, the curve split, which means that more people die from lung cancer if they get chest X-ray as screening, and less people die from lung cancer if they get CT. And this was predicted by this model, and the number of lung cancers then defined here is 1 in 200. So yes, we can reduce the number of CAT scans that we can do by just having a better demographic picture of who we're dealing with. And in fact, you detect 18% more lung cancers using this model, so it's more sensitive and specific. Now, this has to be validated, and that's what everything has to be done. Has to make sure it works in other populations. So hopefully, we're going to give you less radiation in the future based on how we can identify who's at high risk for lung cancer. Well, what about blood tests? Well, let's consider this cartoon. So here's the doctor saying, sure, we can find the disease, and he's going to order all of these tests. And Uncle Sam here doesn't like that because obviously the money that you're going to pay for your health is going to go up. You order all those tests. What this doctor really wants to say in lung cancer is, no, we won't order all those tests. Sure, we can order a blood test that'll then tell us that you need a CT scan because the blood test says you're either at risk or there's something going on compared to a normal person. The blood test is telling us you need to get a CAT scan. And the cost will then go down. Now, are there any blood tests like this? Please, I have grants from the NCI to do those blood tests. And there are hundreds of them that are being looked at. We're looking all over the world for the magic blood test. And we look at protein, and we look at RNA, and we look at DNA, and we look at other proteins, and we look at combination of proteins, and we're just spending all of our money to find the best, the Holy Grail. And none of them are ready for prime time. So this is the buyer beware part of the lecture, which is, I'm not so sure that all the stuff you read on the internet about early CD, this sort of test, that sort of test, that people want you to get at this time, none of them have been approved by the FDA. They're all in some sort of a reference lab, and you really don't have the outcome data as to whether this actually saves lives. So I think that we need to bide our time, get the best sensitive and specific tests, which are coming. What are some of the other things? Well, you would laugh at something like this, that you could actually make a diagnosis from somebody's breath. Well, let me tell you, in in the 1700s, you could walk into a patient's room who had a lung abscess, an infection in his lung that was causing it to be rotted away, and you can smell that patient out the door. That's a breath test. So you knew that patient had a bad problem in his lung. Well, now we have machines that we try to actually measure whether there's stuff in exhaled breath that tells us that a patient has a disease, meaning lung cancer. We also have the biologic equivalent to that in certain studies, and that's our friend here. And yes, there are real dog noses, and yes, there are chemical dog noses, meaning that certain labs have actually looked at what are some of the things in dog noses and then made chemicals and put them into wells and petri dishes and to see whether it changes color when you put a certain breath on top of it. Yeah, we're actually doing that to try and actually reconstruct the nose. Well, the dogs can actually pick it up because they're actually smelling the same sort of stuff that the machines that measure breath exhaled, what called condensate, is doing. This is a crazy person. This is Michael Phillips, who we deal with at NYU and who I've dealt with since about 2004. He actually is the grandfather of doing breath testing in the United States, has a company called Mansana, in which patients actually breathe into this apparatus seen up there. They breathe into it for 10 minutes. There's a little chamber that has a little filter that gets all the condensate. After 10 minutes, you unscrew that. You don't open it up to the air. You send it to a place that does what's called mass spectroscopy. That's a way of looking at certain things in either proteins or in blood or in air to then identify what are all the components of that air. And if you look at that, there are certain components that you can subtract out that are much higher in certain patients. Well, how good is this? This is a curve that measures how good all these biomarkers are, but this is one for breath testing. The sensitivity and specificity would be fabulous if it went all the way up and all the way over. It would be useless if it went from here to there on the diagonal. That means it's just random. So this actually shows that you can discriminate the breath of people who don't have lung cancer from those who do. But this is no good. This is one static thing. You have to do this, like Derek said, in some sort of a randomized or blinded fashion to show that in another group of people that have lung cancer or don't, that you can repeat this. And that would be an accomplishment. Done. Trial that we participated in with Michael, now being published in a different cohort of patients, gives you the same curves, it's the same markers that are able to distinguish patients with lung cancer from patients who do not. So obviously this can be improved, but it's a first step in trying to use non-invasive sort of tests to increase that and enrich the population of people who really need to be followed. Well, finally, be nice to have better imaging. That's already here. NYU has been known for this. And what is this trying to show? This is trying to show that you can follow patients' nodules to figure out whether they are malignant or not. And we used to do it in a two-dimensional way to try and figure out whether the nodule is bigger or not after 4 to 6 weeks. Well, what's shown over here is a volumetric rendering of that nodule. And then 4 weeks later, you see the nodule here. and it's bigger. So that's telling you you've got a growing nodule. And instead of watching that nodule, you should think about whether you should biopsy it or you should remove it. Is this in the real world? Yes, it is. Because this is another one of those huge screening trials. From the Nelson trial in the Netherlands that actually has used this volume-based nodule determination and have shown that you can take different volumes and you can determine whether a patient is at high, low, or medium risk for lung cancer, and how fast it grows as to whether they have a lung cancer. So this is not future, this is now. But what is future, and what I think is going to even augment this more, is this. Here again is the three-dimensional representation of three nodules. But you don't really get an idea of what that's doing. Well, right here, Jane Coe in our radiology department, as well as people in Mayo Clinic, are taking those CT images and texturizing them and pixelating them. So instead of having a nodule that looks like that, they start to look like this. And what that means, those bluish areas that are slow-growing cells, as opposed to the purplish and the yellow areas that are fast-growing cells, you're able to actually take the image, redo it, and you can get an idea of how bad that nodule is. It'll help us to decide go, no go, watch, leave alone, bring back. So I told you it was a 30,000-foot view, but the important thing is that it's all being done here at NYU and at the Perlmutter. And I hope that, we're doing this so that this audience, as well as people that you know out there, can find out that we're here for them, we're doing research, but we also take care of patients to try and cure them of this disease in a minimally invasive way. Thanks very much.